Happy spring. Good morning and welcome, everybody. All right, well, we've got a packed agenda for this webinar this morning. So good morning, everyone, and thank you for joining us bright and early on this beautiful spring morning. My name is Karam Ahmad. I am Colorado Health Institute's Managing Director of Partnerships and Development, and I'm really excited to welcome you to this month's issue of Hot Issues in Health webinar, which we're calling CHAS Data for Changing Times. Really, as we're fielding the 2025 Colorado Health Access Survey, we're reflecting on how this unique data set that we have at CHI helps us make sense of Colorado's really rapidly changing health and social landscape. The CHAS is really a tool and a data set that gives us Colorado-specific data all the way back to 2009, making it one of the very few tools that lets us track long-term trends from major policy changes like Medicaid expansion years ago to more recent shifts in coverage and access. Access to reliable, trendable, and usable local health and social data is so important now more than ever. The CHAS is also a key asset that informs so much of CHI's work with our partners, whether it's helping partners at the state understand inequities or barriers to accessing healthcare or behavioral health, to informing community strategies with community partners that we work with, and supporting our partners and clients with reliable local insights. The CHAS is used in dozens of reports and evaluations and dashboards, and really it's CHI's most ubiquitous resource. When you work with CHI, you get the CHAS. So today we'll explore how that data can shed light on coverage changes, on Medicaid, on uninsurance. We're really going to dive into those issues with really great panelists that we have today, and really the real life outcomes of going without coverage. We know that uh, that's really top of mind for many. So we have really great panelists today who I'll introduce in just a moment. Just some housekeeping. Please feel free to submit questions via the Q&A function at the bottom of your screen for our panelists, and we'll be sure to get to them during the panel. So for those of you that may not be familiar with the Colorado Health Institute, we are a nonprofit public health institute, and that means we help others who are trying to make good decisions about public health and health policy. We can provide data and research, guidance in making decisions, really as a group, and evaluation of how that decision eventually worked out. CHI does not lobby or endorse candidates or legislation, but we do provide evidence as best we can understand it to evaluate proposed policies. So for today's purposes, we're going to be looking at the likely effects of cutting Medicaid, and the evidence you will see will be overwhelmingly against that idea. This does not come from a partisan point of view. It's just the data that the evidence show us. So we're talking today with three Colorado health leaders. So honored to introduce them about how they are preparing for a possible seismic shift in federal funding for health. We know this is top of mind for us all. Adam Fox is the Deputy Director of the Colorado Consumer Health Initiative, which hosts an alliance called Protect Our Care Colorado. Dawn Joyce is Senior Vice President at Impact Health Partners, where she's an expert on federal health policy. And finally, Jenna Ozels is the Vice President of Political Affairs at Color, where she leads outreach campaigns to organize for reproductive justice. But first, my CHI colleagues Joe Hannell and Suman Mathur are going to walk us through some CHAS data to show us really what's at stake when Congress considers health funding cuts. I'm going to turn it over to Joe.
Thanks so much, Karam. I'm Joe Hannell. I'm Communications Director at the Colorado Health Institute, and along with my colleague Suman, who you'll meet in a minute, we put together this presentation that we delivered to the legislature a couple of weeks ago about the possible effects of cutting Medicaid and what that would look like in Colorado if some of these proposals in Congress happen. So our takeaways for today are: first, we can use the Colorado Health Access Survey to show that Colorado's Medicaid expansions over the past decade have solved much of the problem of uninsurance. We used to have a very big problem with a lack of health insurance here in Colorado. That matters because uninsurance is no good for people. It hurts them individually, hurts healthcare providers when their customers can't pay. And then finally, we're going to look at the end of this presentation, shifting away from Medicaid and looking at the private market, specifically the individual market, where there are some tax credits that are really in jeopardy here come 2026. So with that, I will turn it over to Summon.
Thanks, Joe. Hi, everyone. My name's Summon Mather, and I'm a director at the Colorado Health Institute. Here, I've been here for about 3 years, and part of my role is to lead the Colorado Health Access Survey, which we refer to as the CHAS. So what exactly is the Colorado Health Access Survey? The CHAS is Colorado's premier source of data on coverage, access, uninsurance, social factors like food, housing, childcare, and more. Data from the CHAS is really useful because it trends back to 2009 and took place every 2 years after that, including this year, 2025. Our current survey is actually in the field right now. But this data allows us to really see what changes in Colorado have occurred over the past decade plus, which can help us understand and think about how some of those different Colorados look and what that might mean for the future. And finally, the CHAS is an independent data source that's used by policymakers, state and local agencies, community-based organizations, and more for policymaking and research. To really understand the potential impacts of some of these federal changes that Joe will speak about, we'll use CHAS data to ground our understanding of what this might mean in Colorado. So let's start by looking at insurance coverage from 2009 to 2023, looking at the uninsured rate over that period of time. So if we take a look at this graph here, you'll see that from 2009 to 2013, the uninsured rate in Colorado hovered between 13 and 16%. Then between 2013 and 2015, something pretty drastic happened, and the uninsured rate was cut nearly in half from 14% to 7%. Many of you probably realize this as being when the Affordable Care Act went into place. In 2014, Colorado expanded Medicaid coverage to include additional populations that were not previously covered by Medicaid. And both our analysis through the CHAS, as well as those by many of our partner organizations, have in fact concluded that much of this drop in halving in the uninsured rate was in fact due to Medicaid. Many folks who were previously uninsured did in fact end up getting coverage by Medicaid and thus becoming insured. Now, between 2015 and 2021, our uninsured rate stayed pretty stubbornly at 6.5%, with really no change over that period of time. But then, over the course of the COVID-19 pandemic, we finally saw a drop between 2021 and 2023 to our lowest ever recorded uninsured rate on the CHAS of 4.6% in 2023. Now, during that time, the public health emergency went into effect, which allowed for individuals who were covered by Medicaid to stay covered by Medicaid without having to re-enroll each year. This was its own type of Medicaid expansion, and we think may have contributed to that drop in the uninsured rate. Now, I do want to note that our 2023 survey went into the field while the public health emergency, or right around when it ended, which meant that individuals had to then start re-enrolling in Medicaid, which may have caused a little bit of noise around this data point, and it's one that we are really interested in seeing in our 2025 data. So now that we've had a chance to look at uninsured in Colorado, let's take a look at what insurance coverage looks like across the state. Again, looking at our 2023 CHAS data, we can see how different types of insurance coverage vary from health statistic region to health statistic region. Now, these are either single counties or groups of counties that we group data together to really understand how things looked geographically in Colorado. Let's first look at insurance coverage by the way that most Coloradans get their insurance, which is through their employer. Looking at the map on the screen, you'll see right in the center of the map in Colorado, we have a dark green Douglas County, where nearly 69% of the population is covered by employer-sponsored insurance. This is also pretty high coverage rates across the Front Range, but if we look out to our rural communities, specifically Northeast Colorado, Southeast Colorado, and other parts of the southwestern part of the state, we see lower rates of coverage by employer. Now let's take a look at Medicaid coverage, again in 2023 in Colorado, and we see pretty much the inverse here. If we look at the map, we see really dark shades of blue in Northeast, Southeast Colorado, Pueblo County, and parts of our mountain communities. In some of these communities in 2023, we estimated the rate of Medicaid coverage to be upwards of 50% of the population. So a really critical resource to many of these communities in our rural parts of the state. And finally, let's take a look at insurance coverage through the individual marketplace. Individual coverage refers to insurance that is purchased directly from an insurer, including through the Connect for Health marketplace. And we see higher rates of coverage through this form of insurance in the northwest part of the state, the southwest part of the state, and in communities like Boulder, Broomfield. We think this probably has to do with the economies of these regions, where folks might be in multiple part-time jobs, or they might be working as remote contractors or independent contractors. This is in some of these parts of the state about 10% of the population. Now I'll turn it over to Joe to talk a bit more about what we can expect to see when it comes to Medicaid coverage.
Okay, thanks, Simon. Right now, Congress is debating budget choices that could end up cutting hundreds of billions of dollars in federal Medicaid spending in the next decade. We're not going to get into the specifics because the specifics change very, very often. But we've heard this number, $880 billion, being cut out of the committee that oversees Medicaid over the next 10 years nationwide. So that's more than 10% of federal Medicaid spending. And this would force some really tough choices for us here in Colorado. Medicaid is the state's single biggest, the state government's single biggest expense, and it's growing because healthcare costs are growing. When people lose Medicaid eligibility because of a policy change, not because they're getting paid more, but because the Medicaid system changes, what happens to them? Well, it's most likely that most of them would become uninsured because of the data that someone just showed you. We had a bunch of people who were uninsured, Medicaid expanded, they became covered. If Medicaid contracts, we're guessing a lot of those folks will become uninsured because health coverage just has not gotten less expensive over the years since we saw that big expansion in 2014. So let's look at what we would expect to happen as a result of Medicaid cuts. Kaiser Family Foundation did some modeling. So these are not CHI numbers, this is KFF, our kind of go-to national analyst for modeling like this. They proved very reliable in the past. KFF predicts more state spending and fewer people enrolled in Medicaid in every state, all 50 and District of Columbia, under two parts of the House budget plan, putting per capita cap on Medicaid and eliminating the extra federal funding for Affordable Care Act expansion. So under Kaiser's projection, Colorado would be looking at a reduction that in Medicaid rolls that would build to 18% or possibly up to even 41% 10 years from now, depending on what policy the House adopts. So who would that affect? Someone's going to look at who is actually on Medicaid in Colorado, according to our CHAS data.
So we'll first look at this through a few different demographic factors that we captured through our 2023 CHAS. So looking at Medicaid members in our 2023 CHAS, we found that about just over half, 54%, were male, while about 44% were female, and others fell into other sex and gender categories. Next, if we look at race and ethnicity, we find that about half of the Medicaid population in 2023 was white, with the next largest race ethnicity group being Latino Coloradans at about 35%. Black Coloradans made up about 5% of the Medicaid population, and Coloradans of other races made up about 10.5%. If we look at age, it's probably no surprise that children ages 0 through 18 make up the largest slice of the pie here at about 29.8%, or just over a third of the Medicaid population. Coloradans ages 19 through 29 make up 12% of the Medicaid population. 30 through 49, just under a quarter. Ages 50 to 64 at 21.7%. And Coloradans ages 65 or older at 12% of the Medicaid population in Colorado in 2023. Okay, finally, let's take a look at how Coloradans on Medicaid shake out in terms of employment status. As Joe mentioned, there are a few different ways that the federal government is looking at making changes to Medicaid. One of those might be work requirements. So looking at our 2023 CHAS data, we see that about 34% of the Medicaid population, ages 16 and over, are employed. Another 42% identify as Coloradans living with a disability. However, it's important to note that within that group, about a quarter are also employed, as these are not mutually exclusive categories, though we're displaying them as discrete categories on this graph. Of the remainder of Coloradans, the percentage that is unemployed but not looking for work is just about 2%, so a small portion of the remainder of the pie. Of the rest of Coloradans that are unemployed, that's made up of a combination of parents, those who are unemployed but actively seeking and looking for work, as well as those who are retired or may actually work for a family business but not receive a salary. So let's talk a little bit about what things might look like, or what things have looked like in the past when people were uninsured, again, looking at our 2023 CHAS data. And put simply, when people are uninsured, they can't afford care. On this graph here, we see the percentage of Coloradans who report that they skipped care. This is a combination of physical health care, specialty care, prescriptions, because of cost. And we see that those who are uninsured, over half report that they had to skip needed care because of cost. This is in stark contrast to nearly every other type of insurance coverage, and is a concern when we think about affordability and ability to access care. Next, we see that when people are uninsured, they are less likely to go to the doctor and use care. 88% of Coloradans who were insured had reported seeing a doctor in the last year. They may have been getting their annual checkup, which is covered through the Affordable Care Act by their insurer, or seeking other types of care. In contrast, only 39% of those who were uninsured sought care in the past year. Now, what does this mean for the providers in Colorado who are responsible for providing high quality and compassionate care? We know that even though uninsured Coloradans are much less likely to seek care, there is going to be a percentage who are still going to need care for potentially urgent issues. And this causes some issues for providers who will continue to provide that care regardless of compensation.
Thanks, Simon. We're going to shift now to looking at the individual market. And we're doing this because the individual market might be a lot smaller than Medicaid, but it's often considered to be the first alternative for people who no longer qualify for Medicaid, but might not have a job that offers health insurance benefits. So just to review the basics, this market is where people buy directly from an insurance company. This is Connect for Health Colorado. That is where a good deal of the individual market takes place. People can also buy through a broker or on their own. However, tax credits are only available through Connect for Health. And just this winter, Connect for Health announced 237,000 people, a little bit of a difference there, enrolled in Connect for Health. That's a record in the history of this insurance exchange. And more than 3/4 of them got these tax credits. We do have CHAS data on the individual market as well, and Simon will take us through just a little bit of that.
As Joe said, one of the data points that we capture in the CHAS is around the individual marketplace. And my colleague Chrissy recently did some analysis, and that's posted on the CHI CHAS webpage if you want to see more data points around the individual marketplace. But to start, our conclusion around this is that it's difficult for Coloradans on the individual marketplace to find providers that accept their insurance, with about 22% of Coloradans on the individual marketplace indicating that they did not get care because a provider didn't take their insurance. You can see that on the blue line here on this graph, and unfortunately this is a trend that we've seen increase over the past decade or so. Another data point that we look at is whether individuals and Coloradans who receive health insurance keep that health insurance. And there might be a few different reasons why someone doesn't, but we do see that Coloradans on the individual marketplace are more likely to have lost their coverage following having received it, with about 26.5% reporting that they had lost coverage in the 12 months since prior to the survey. Again, if you want to see more data around the individual marketplace, be sure to check out our CHAS brief on this topic on our website.
So unfortunately, there's a reason that the individual market is relevant today, beyond just that's where hundreds of thousands of Coloradans get their coverage. It's because there could be some upheaval at the end of the year. The Inflation Reduction Act from the Biden administration boosted those tax credits that are available for purchasing coverage on this market, which is otherwise really expensive. It made the tax credits worth more, and it removed the income cap that had prevented a lot of middle-class people from getting the credit. Those tax credits are set to expire at the end of this calendar year unless Congress acts. So this is unlike the Medicaid cuts we're talking about, or the potential Medicaid cuts from Congress, where Congress would have to affirmatively act to cut funding. Here, Congress would have to act to extend these tax cuts, and if it does nothing, then the tax cuts will go away. What would happen in that case? Well, we're going to turn again to KFF for some national modeling. This is modeling from for Colorado's 3rd congressional district on the western slope, which is it tends to be the most expensive individual market in Colorado. And they looked at what would happen for a 60-year-old couple making $82,000 a year and a 40-year-old single person making $31,000 a year. Without those tax credits, there are dramatic increases in the monthly premium for both of these folks. The 60-year-old couple would go from paying $580 a month, which is already quite a bit, up to nearly $2,400 a month. The single person who's right now paying just $58 a month for a silver plan, their price would nearly triple, up to $153 a month. So that's how we can use the CHAS, combine it with some national data, and be able to make some predictions about some of the policy proposals that are going on here. We have a new story online that shows the Medicaid portion of this. You can, if you're quick on the draw, you can grab it with this QR code. If not, don't sweat it. My colleagues are going to drop the link in the chat right now. And before we queue up our panel, I want to invite you to our next webinar, April 24th at 8 a.m. Building Bridges for Better Health. We're going to explore how clinical community linkages are advancing chronic disease prevention and management. And this has been a big portfolio of work at CHI for many years now. And again, we'll drop the registration link into the chat here. So now let's turn it over to, let's bring up our panel.
All right, hi everyone. We're really pleased to be joined today by Adam Fox from Colorado Consumer Health Initiative, Dawn Joyce from Impact Health Policy Partners, and Jenna Ozels from Color. So we just heard a lot of data about how Medicaid has helped Colorado partially, substantially solve our problem with uninsurance. And then what happens when people are uninsured? I want to give each of you a chance to kind of talk about your organizations and what you're doing, starting with you, Adam, because I know you're tracking very hard on this question. So tell us about what CCHI and Protect Our Care Colorado are doing.
Yeah, thanks, Joe, and good morning, everybody. My name's Adam Fox. I'm the Deputy Director at the Colorado Consumer Health Initiative. I use he, him, L pronouns, and appreciate the invitation to speak with you all this morning. We have been working at the Colorado Consumer Health Initiative for almost 25 years now to really protect access to healthcare, make sure that it's equitable and affordable for Coloradans. And I think what we're seeing at the federal level with the threats, both to Medicaid and to private insurance coverage, is incredibly concerning. What we know in Colorado is we just went through the public health emergency from COVID. There were over 500,000 Coloradans who were disenrolled from the Medicaid program, and that has already strained a lot of our providers and rural hospitals and our healthcare system as a whole. Medicaid is really the foundation of our healthcare program, our health coverage systems in Colorado, and so if these cuts go through, it really puts us in a bind at the state level to be able to cover all the Coloradans who were able to cover today. So what we've been doing is similar to 2017 and 2018 when ACA repeal and similar, though less dramatic Medicaid cuts were on the table, we have relaunched our Protect Our Care Colorado coalition really to educate and build awareness of what these cuts would mean and what their impact would be to different populations in Colorado, our healthcare systems as a whole, and really trying to educate our congressional delegation about why these cuts would really have a devastating impact in Colorado. We have very particular budget constraints here in our state, and that would make it very difficult, really impossible, frankly, to make up for any federal cuts that we are seeing proposed. And so what we have been doing through the Protect Our Care Colorado Coalition is really working to mobilize action on these potential cuts and trying to educate and raise awareness. So that includes really trying to mobilize community and folks who would be directly impacted, working to collect people's stories and help them share their stories about how healthcare impacts their life, how Medicaid impacts their lives, raising the profile of those kinds of stories in the media. But we're also working to really coordinate across organizations and with different healthcare stakeholders. Our coalition is just shy of 50 organizations currently, and it's sort of steadily growing as we go along. And so it's coordinating all of those groups and trying to make sure that we're engaged in activities that we think are going to be helpful in raising the profile of what these cuts would mean, pushing back on some of the misinformation that we're seeing on those cuts. but also working to coordinate across other stakeholders who are working to fight against these cuts, including a variety of healthcare providers and stakeholders. And the other thing that we've really been trying to do through the Protect Our Care Colorado Coalition is really create and compile tools that people can use to communicate about what these cuts would mean. So that includes creating and compiling fact sheets. We have a sort of a slew of graphics and messaging and talking points that people can use. Our protectourcareco.org website has call scripts that people can use to contact our congressional delegation, an email contact page, our sort of story survey to collect people's experiences with Medicaid and ACA coverage. All of that is sort of in one place on our campaign website. And we're trying to continually add and build information out, especially as I think some of these cuts get a little bit more concrete in the conversation in Congress and in DC. So really, as a whole, Protect Our Care Colorado is focused on really raising the profile of what the impacts of these cuts would mean for Coloradans, people who are currently enrolled, people who may need Medicaid in the future, what it would mean for our healthcare providers, particularly safety net clinics and rural hospitals who are really at risk if these cuts go through of, at best, probably reducing services, but at worst, closing their doors altogether. But I think a lot of people don't understand how much of an economic driver Medicaid also is. So we're trying to compile information about sort of the economic impact that Medicaid has in the state as a whole, but in specific communities and districts as well. And then, as I highlighted earlier, sort of the impacts to our state budget. If these cuts go through, we don't have the flexibility in Colorado. Really, no state does, but Colorado in particular, with our constraints, we do not have the ability to sort of make up for any cuts at the federal level. And I think what that would mean is we would be forced into really challenging decisions about how much healthcare we can provide as a state, frankly, how much coverage we can provide, versus other spending priorities that we know are really important to everybody in the state. So that's what we've really been trying to do, and we welcome folks to join the Protect Our Care Colorado Coalition and use our tools that we've been sort of compiling and building over time here.
So a lot of education about this program that, frankly, I think a lot of folks take for granted because it is just such a foundational part of health in healthcare in any state, Colorado included. Before we get to Dawn, I want to just make sure everybody knows we really invite and encourage you to ask questions of this panel. Summin and I don't have a full script that'll keep us going for the next 20 minutes. So please, I think we've already gotten 1 or 2 questions in the Q&A. You can use that or the chat. Someone's going to be monitoring that. And as soon as we get through a couple of questions here, we will open it up to audience questions as well. Dawn, could you tell us about Impact Health Policy Partners and what you're seeing as the current thinking in Congress?
Good morning, everyone. My name is Dawn Joyce, and I'm a Senior Vice President with Impact Health Policy Partners. We're a small 11-person health policy firm. I live here in Colorado and have for almost 20 years. And we specifically focus on health policy and the full spectrum of what that means for those of us who, like myself, have come to this through public health. So we collaborate with foundations, counties, providers, et cetera, and help them understand what is actually happening in the federal health policy sphere, and then how to advance their goals in that respect, and or how to leverage opportunities when those exist at the federal level to create programs, policies, et cetera, at the state and local level. And my own background is that I have worked for CDPHE and also at the counties, and then with all of our foundation partners here creating Colorado Peak many years ago. So I bring both a federal perspective and then a state and local perspective as well, and have worked with many of you who are attendees here for the last 2 decades, really to expand what you highlighted in terms of the coverage gains we have made. And many of those are enormously at risk, as has been illustrated earlier in this call. So I'd really like to add 2 things to this conversation. One is to share a little bit about budget reconciliation, what that is as a vehicle for Medicaid cuts, and what the timeline looks like. And then second, what are the top things that we're currently hearing on the Hill in DC and across the Hill in the White House in terms of what the top Medicaid cuts are that are under consideration and how those are being characterized. So I'm going to share that from a very high level for the sake of time. And then as we're in conversation, happy to dive in deeper, etc. So budget reconciliation is the congressional vehicle through which various changes can be made with a simple majority in the Senate. The key here is that otherwise the Senate needs 60 votes to overcome the filibuster. Through budget reconciliation, which has many, many rules and is very complex and rigid, you just need 50 votes. You need 51 votes, but the vice president can be the tie-breaking vote. So given the trifecta that currently exists at the federal level, really the margin that they're looking for is just 50 to pass budget reconciliation. There are lots of rules about budget reconciliation that we can always touch on, but the key piece is that where we currently stand is that the Senate first passed a budget resolution. So the way that this works is that Congress first passes a resolution that includes specific instructions to committees as to what to achieve from a budgetary perspective. That could be spend this much, it could be cut at least this much, cut up to this much, etc. And it's not a clear piece. So when the Republicans say, I haven't voted for Medicaid cuts, they haven't technically voted for Medicaid cuts by voting for it, but it's a direct domino effect. So where we currently stand is that the Senate passed a budget resolution that directs its relevant committees who oversee Medicaid to cut $1 billion from programs that they oversee, of which that would then likely be Medicaid, because there's limitations on budget reconciliation and only certain things fall within jurisdiction, hence that domino effect. On the House side of things, that's where the $880 billion mark is. This is where that resolution directs the Energy and Commerce Committee, of which 93% of what it controls is Medicaid, to cut $880 billion. If the administration keeps its promise that it won't touch Medicare, that means the vast majority of that will come from Medicaid if they continue to pursue this. So that's the piece where you have one side saying you have put Medicaid cuts on the table and another side saying they haven't, because they haven't technically taken that vote. Where we currently stand is 2 very different places, and both sides of Congress are at a standoff with this. The House believes strongly that the Senate will take up its version and pass it. The Senate is sitting tight because it doesn't want to do so. And can you still hear me? Oh, thank you. This is helpful. And the Senate side is currently pursuing a 2 budget reconciliation approach, whereas the House is wanting to pursue 1. So they're in 2 different places in terms of the overarching amount, the number of times they might do this, and various other things in terms of what to include. So they very much currently are in 2 different places. As they've just come back from recess, the key piece is that they actually, to be able to move forward, they have to get on the same page and pass identical budget resolutions. The Senate cannot actually proceed with the ability to do this by 51 votes until that has happened, hence how it is indeed a restrictive set process. So what you're having here, just as a visual for those of you who are visual, is what are the different steps that still need to happen to actually pass budget reconciliation? And most importantly, what are the opportunities for impact that creates in terms of timeline? Originally, the Republican Party had hoped to complete this by the end of the president's first 100 days, which is the end of April. That does not look likely. It is important to know that they have passed things through very razor-thin margins, like the recent continuing resolution. So it's important to know this could happen Or in a best case scenario, we might be in a place where, like we staved off the attempt to really dismantle the ACA during the first administration, my best possible hope is we can achieve that here. I think it's crucial to really look at what is on the table for Medicaid cuts and how to potentially minimize them and to be full throttle in this advocacy. What you have here along the bottom in the orange ovals is the timeframes in which the individuals from Congress will be here in district or are scheduled to be. This can change slightly, but these are crucial windows of opportunity, whereas on an ongoing basis, there's an opportunity to weigh in at the federal level and with your district offices. And then these are the specific timeframes in which to be able to really weigh in at the local level. So what we think we're in terms of timing is that they're currently working on, can we come to an agreed upon place? It's a little bit of a game in terms of who will blink first to do that. Lots of conversations about it. We will not see the Senate proceed with any markups until that has actually happened. So what a markup is where you actually look at what policies are on the table and talk about those. We do know that on the House side of things, they have at least 3 different scenarios that would allow them to reach the $880 billion. They're not going public with those. They don't want their members to take votes on those because it's harmful politically until it reaches the point where it actually could move forward. But that's where they currently stand. So they have to come to an agreement about budget resolution, and then each side will, which could necessitate other floor votes, and then each side will go through an actual public markup process where we'll see what the policies are. Then there will have to be agreement between those before eventually passing it. What this is looking like is that we're likely to see at the earliest the markups in May. This is the key piece to what has been mentioned. Adam, what you said in terms of, okay, when we actually see the concrete policies, then we can address what their impact will be. Right now we're addressing, we know what's potentially on the table, but that is where we could narrow in more. So in terms of potential actual passage, earliest June into July, they are going to likely hope to do so before the August recess. We could see this extend into the fall once they're back from August recess. It's okay to take down this slide. I'll just do 1 more minute or 2 more minutes on what the key Medicaid cuts are, and then we can dive into those in our discussion. The top things that we're seeing, essentially, actually, there's 2 different schools of thought here. The Republican Party in the White House is saying, we won't cut Medicaid benefits, but we will address fraud, waste, and abuse. The Democrats are saying, your attempt to address fraud, waste, and abuse is necessarily going to cut benefits. 2 different sides in a very simplified way. What are the top things that are on the table that are crucial that we know? And I want to make sure everyone's aware there's a great fact sheet that HCPF has created that actually dives into various pieces of this, what it specifically means in Colorado, et cetera. It's fantastic. And I look at a lot of these kinds of things all the time. Anyway, just kudos to the staff that created that and likely other partners who are part of it. So number 1 is Medicaid work requirements, as mentioned. And thank you for all of the data that you're releasing with respect to this and highlighted. Number 2, potential changes in the FMAP. What I'll just add to what CHI has already noted in that respect is that what we could see a change in is that currently our Medicaid expansion population is funded by the federal government at 90%. We pay 10%. When they say we want to equalize it, make it equal so that we're paying the same for various populations, which is part of their argument to get back to the core of what, in their view, the program was intended to do. Currently, that could bring us down to 50% because that is our FMAP rate otherwise for various other things. What's key, and that's an enormous difference, 90 to 50, right? Not to be underestimated. What's also important to know, however, is that there is also dialogue about removing the FMAP floor. FMAP is the federal, how we calculate what the feds pay versus what states pay. If we were to remove that floor, we're one of the wealthier states to whom we would then drop to a lower level. There's just a handful of states where that is true for, so we could see it not just go from 90 to 50, but potentially even lower. And as Adam highlighted with Tabor, et cetera, we cannot make up that difference. We are talking about just truly draconian potential cuts. And then the third piece that I'll note is that in terms of fraud, waste, and abuse, there are a few things that they're classifying under that currently. One is provider taxes. So in Colorado, we currently pay for a portion of our state financing of Medicaid using a provider tax that we've had in place for a long time. They're considering changing how many, essentially the rates at which you're allowed to do that at, which would diminish our ability to provide our share of Medicaid financing. They're also considering various immigration pieces with this distinction between citizens and non-citizens. When you look at non-citizens, that is an individual who's pregnant, who's having a baby. It's all kinds of various pieces of immigration statuses, but that can be put into black and white terms. Additionally, it's what they see as the need to make more restrictive our eligibility processes and requirements. CHI highlighted that change from 6.6 to 4 point something percent when we actually had continuous eligibility. That is where, if instead we see a reverse with more frequent eligibility determinations and or the less ability to do the many streamlined things we have built into the Colorado processes over the last decade plus, we will see a reduction in coverage, not because people aren't necessarily eligible. That will sometimes be true, but because of the process that it creates. So lots of things at the table that are specific with Medicaid. Key things to know at the federal level are this will happen through budget reconciliation. If it happens, we have crucial opportunities to advocate, and we'll be learning more and more about what they specifically they're thinking as time goes on. But it's a gift of time that they haven't been able to get it done yet, and advocacy is increasing. Thank you.
Don, that is fantastic information all the way through. I'm hearing that there's a legal process for this. This isn't happening by fiat like a lot of things are happening in Washington right now, and that there are a series of votes coming up, and those are pressure points because those are going to be hard votes for members to take. I want to make sure we give Gina some time and then time for our audience questions as well. Or Jenna, I'm sorry. My apologies. Jenna, please tell us how you see it. We see it from Color's perspective.
Yeah, no worries, Joe. Thank you so much for having me. Yes, Jenna Ozols. I am the Vice President of Political Affairs at COLOR Latina. COLOR stands for the Colorado Organization for Latina Opportunity and Reproductive Rights. We are specifically a reproductive justice organization. And so what that means is, unlike the reproductive health or rights space, reproductive justice is by definition women of color led and women of color serving, and really recognizes those different intersections, those social determinants of health that really so impact how our communities access care. And when I say our communities, yes, elephant in the room, I am a white lady who happens to be in a leadership position with an RJ organization. So you're not asking weird questions if that popped up in your head, because we are women of color led. And so because of that, that we are primarily led by Latinas and serve Latino communities, we have become a very trusted messenger for that community in Colorado. And so because of that, that has allowed COLOR to create somewhat similar to the CHAS, actually, Suman, is our Colorado Latino Policy Agenda, which is a statewide public research initiative that engages 1,600 Latine registered voters. And we release one every year. I'll be happy to drop the link into the chat for our most recent, comprehensive, nonpartisan snapshot of Colorado Latino policy priorities. This is an ideal way to hear directly from the Colorado Latino community about the issues that are important to them. And when it comes to healthcare and Medicaid, I mean, it is exceedingly clear that Latinos in Colorado depend on and value affordable healthcare programs like Medicaid. Like in previous years, the 2024 results showed that lowering healthcare costs was once again ranked amongst the top 4 priorities that voters want their elected officials to address. And this is a consistent thing that our data shows us in every year that we have done this research for the past several. And we know that, like many people, Latinos are facing severe economic challenges, meaning any cuts to Medicaid would be absolutely devastating. And we've already seen significant and I went dyslexic for a second. Latinos have already experienced significant interruptions to the continuity of their care, and including 1 in 4 Latinos in Colorado have actually been dropped by Medicaid in the last 2 years, which is, you want to talk about devastation, that is absolutely devastating to a community. And so, we're not just seeing, as, Dawn so eloquently, walked us through, we're not just seeing potential cuts at the federal level, but also at the state level. And this is where, COLOR is encouraging and supporting our community to reach out to state lawmakers in addition to our federal lawmakers as well. We engage with our community at local events like our La Platica series, our youth programs like Youth of Color and Latinas Increasing Political Strength, or LIPS, and of course, direct canvassing and phone calling efforts. We also do public wheat posting campaigns. So if you've ever seen like on a wall where it's all covered in the one, the one advertisement, reproductive justice for all, linking to information on how folks can actually enroll safely in the programs that are still offered. And safety is a huge issue right now, obviously, for the Latino community. There's a lot of distrust with government right now, which just creates this additional barrier towards being able to actually get folks enrolled and keep them enrolled as well, even if they are actually eligible and not one of the 1 in 4 Latinos who has been dropped from the rolls in the last few years. We do this advocacy to our state lawmakers, and we actually just concluded our Latino Advocacy Day, which had over 400 participants at the Capitol lobbying their members just last weekend. And we are very excited to be taking our Latino Advocacy Day to DC for the 2nd time this year, where we will be in DC with a group of folks in September. And LIPS, actually, who I mentioned earlier, will be in DC in a couple of weeks, specifically to talk to and advocate with our elected officials. And healthcare is always one of the top things, regardless of age, that comes up as a priority for folks to lobby and communicate on. And so we're very excited to take this group of young people in a couple of weeks, very excited to take this other group of community members in September. But to those state lawmakers, there are currently budget cuts that are being considered that are absolutely massive to our affordable healthcare programs. These cuts include reducing Medicaid eligibility for kids and pregnant people who qualify for Child Health Plan Plus, eliminating family planning coverage for all Coloradans by cutting the reproductive health care program, and stopping funding for health insurance for kids and pregnant people by eliminating coverage options like Medicaid through Cover All Coloradans. And we at COLOR, and I'm sure I'm kind of preaching to the choir here, but we do not believe that taking away healthcare from children, parents, or pregnant people, that is not the solution, and is going to actually end up costing us more money down the line. We know that healthcare needs do not just end because people don't have insurance. Healthcare is a right, and Colorado lawmakers, in addition to our federal lawmakers, need to work to uphold that. And frankly, to be on a soapbox a little, especially when we are seeing these threats from the federal level, it is truly incumbent upon our state legislature and our state officials as well to be doing whatever they can to ensure that there are no cuts, or as few cuts as possible that are happening in state, because we have got to be taking care of our folks here as much as we possibly can, given what is happening in DC. So I could go on, but I'll jump off the soapbox because I want to make sure that we've got a few minutes for those questions. But thank you again for having us, Joe, and Suman. It's really great to be here.
Of course. Thanks so much, Jenna. Simon, what are you hearing from the audience?
Yeah, getting some questions around some clarifications. Actually, maybe Don, this first one you can respond to. So Sydney asked about the work requirements that are being discussed at the federal level and how that would impact children, right? We saw that nearly a third of the 2023 Medicaid population in Colorado are children who likely are not employed. So how would that impact children, and what other groups are part of that discussion or perhaps excluded from some of these work requirement discussions?
Great question. So it's important to know that we have no details as to what will be included. There are processes underway to dive into what kind of policy language to keep an eye out for that would be poison language, what kinds of language to advocate for if this were to move forward, what to include. A key piece of that is exemptions. So to your question of how would it impact, so no, a child would never be required, or anyone, to meet a work requirement. But if their parents have that requirement, and the parent is currently a caregiver in an unpaid job, Riley. It's not that they're not working. I have 3 young children. Okay, they're working however many hours there are in a week. But they currently, in other programs, have exemptions for a parent, for example. Sometimes it's based on the age of a child, etc. A lot of what's currently happening is looking at SNAP, for example, at what kinds of exemptions do they have? What exemptions would be included in the policy? To be determined, right? Sometimes you hear best case scenario, just able-bodied adults without disabilities. The thing is, we know that in that population, many of them do have disabilities. It's that it's based on the definition of disability. If they weren't receiving SSI, then they didn't qualify under disability under other pieces, but it's not that they're not individuals with disabilities. So there's sort of 2 key takeaways I'd say with this as the conversation about Medicaid requirements evolves. One is the exemptions. So who is exempted, including potentially veterans, seniors, what age is the cutoff, etc. 2, what are the definitions that are used? So for example, when you define disability in some programs, and we're kind of deep in this with some individuals at the county level here, actually, to try to better understand what to potentially advocate for. They're self-reporting, so someone could have something like ADHD, but they don't currently know in other programs that if they report that actually could exempt them from certain requirements. How does that play in here? Similarly, definitions around homelessness and what does that look like, and self-reporting, etc. And then actually I said 2, but I'll really tell 3 things. The third one is really keeping an eye for blockades on future coverage. In other states where we see these in place, if someone doesn't meet them and loses coverage, they are blocked out for a calendar year. That means that if all of a sudden they are able to submit the paperwork to demonstrate that they made the exemption, they still don't qualify for coverage then until the end of that a calendar year. So those are some key pieces, but all to be determined because it's all behind closed doors right now what's being discussed.
Thanks, Don. Adam, did you want to jump in?
Yeah, I would just add that pretty much no matter how work requirements are implemented, it affects everybody in Medicaid. Everybody who's trying to enroll in Medicaid, even if they are subject to an exemption, they have to prove that exemption by and large. And so it adds administrative burden and barrier to everybody who's trying to enroll in Medicaid, regardless of their status. And so I think it has a pretty devastating impact, and we've seen some pretty extreme estimates, I think, as to how many people could be disenrolled from Medicaid or be blocked from Medicaid if work requirements are implemented. And then Dawn alluded to it, but I also wanted to put a finer point, is Colorado is one of the few states where counties administer Medicaid enrollment. And what we have seen from states who have implemented Medicaid work requirements is they have skyrocketing administrative costs. And that would have a direct impact on county level government and county level resources, to really a devastating impact. It would lead to delays, it would lead to errors, it would lead to people losing coverage. So work requirements are cuts to Medicaid, plain and simple.
Thanks, Adam. I think we have time for one more question. So we had one about how federal budget cuts to Medicaid might affect the budget of other programs like OmniSalud. Would anyone like to respond to that?
Sure, I can start. I think so. OmniSalud and sort of the primary structure that funds the OmniSalud program, which subsidizes coverage to folks who are not eligible to enroll under the Affordable Care Act or Medicaid otherwise, which currently is really folks who lack documentation status. Essentially, that program was really designed to keep those funds really separate from the state budget, and also to an extent from the federal sort of budget conversations. But I think what we could see is if all of these cuts go into place, and if coverage for, say, Cover All Coloradans is targeted, it means that there are going to be more people who need OmniSalud coverage, then we have resources to provide. And we already don't have enough resources for that program, and it would sort of put further strain on it. So it doesn't necessarily affect the current funding, but it would affect sort of the population who needs it.
Thank you.
Well, Jenna and Don, Adam, 9 o'clock has arrived. I want to thank you so much for sharing everything with us this morning, including all these resources you're sharing in the chat. Anybody who's registered for the webinar will get those links in an email from CHI later today. And just to wrap up, this is a big deal, what we're talking about. We haven't confronted anything quite like this certainly in my professional life, but I'm feeling a lot better than I was an hour ago after hearing the three of you and others like you are really tracking this and locked in and providing all these resources for us. So thanks a lot, everybody, for joining us. Thanks for the work you do. And we'll see you next month at Hot Issues and Health webinar.
Thank you.